Good day, everyone, from whatever time zone you are in and wherever you are logging in from. And welcome to our webinar, Engaging Priority Populations, Community-Centered Hyperlocal Strategies for Diabetes Prevention and Care. My name is Keith Akins, and I will be your moderator today. I'm a health communication specialist for the Health Education and Promotion team in the Division of Diabetes Translation at the Centers for Disease Control and Prevention. By way of inclusive introduction, I will describe myself as a Black male with bald head. I'm wearing black-rimmed glasses with a shirt and jacket. My virtual background is white with the CDC logo in the upper left corner. And I invite our guest speakers today to do the same if they feel comfortable. Before we begin, we're required to share this disclosure statement. CDC, our partners, planners, content experts, or their spouses and partners wish to disclose they have no financial interest or other relationship with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. One webinar speaker featured today, Cut for Health, is a CDC-funded program. Planners have reviewed content to ensure there is no bias. The content presented will not include any discussion of their unlabeled use of a product or products under investigational service. CDC did not accept commercial support for this continuing education activity. There are no fees charged for CDC continuing education activities, and the findings and conclusions in this presentation are those of the authors and do not necessarily represent the views of the CDC. Now, this program has been approved for CNE, CEU, CECH, and CPH credit. To receive the credit, please complete the course and take the post-test available at www.train.org/cdc.train. A registration code for this activity is required. The code is the word priority, and you'll see the website and the registration code on the slide. Please note, if you have never registered at CDC Train, you will have to create a new account. Returning users should log in with their existing username and password. This webinar is being recorded, and an email will be sent out once the recording is available. The recording also will be approved for continuing education credit. These slides and a transcript of the webinar will be made available with the recording. Now, during the webinar, if you have a question for our speakers, please type it into the Q&A box at the bottom of your screen. If you want to direct your question to a particular speaker, please feel free to note that in your question. We will do our best to answer all questions during the Q&A portion of this webinar. If you have a question about obtaining continuing education credits, where to access this webinar once it's over, or other technical questions, please use the chat box feature at the bottom of your screen. Now, let's get to today's objectives. They are to recognize challenges faced by populations of focus in preventing type 2 diabetes and/or living with diabetes, identify barriers for participation and retention in type 2 diabetes prevention and diabetes management programs, describe strategies for improving recruitment and retention in community-based diabetes programs, and describe methods healthcare teams can adopt to more effectively support people living with diabetes or at risk for type 2 diabetes. Now, while everyone is welcome to join type 2 diabetes prevention and management programs like the National DPP, and diabetes self-management, education, and support services, not everyone has the same opportunity and ability to access them. Across the United States, some racial and ethnic minority groups and people with lower socioeconomic status historically have had higher rates of developing type 2 diabetes or diabetes complications. The challenges of managing a complex chronic disease like diabetes are often compounded by barriers in access to needed and resources and services. Some of these barriers you can see on the slide in front of you. But these barriers only paint a broad picture of the challenges in delivering diabetes services to populations of focus. For people to live at their highest possible level of health, it's important to provide access to tailored diabetes care and support services that meet people where they are, in the places where they live, work, learn, play, and pray. So now we're looking for our presenters. Today, you're going to hear from several organizations on the incredible work they're doing to enhance awareness and utilization of type 2 diabetes prevention and diabetes care services through hyperlocal, culturally nuanced engagement strategies. Their work addresses the unique needs of their communities, but we hope that when you hear their experiences, you can glean some lessons and strategies that you can tailor and apply to your work. So joining us today are Doctors Sarah Johnson and Stephen Thomas from Cut for Health. And they'll be talking with us about partnering in local and familiar spaces to build trust in a community. And next, we'll hear from Dr. Antonio Miranda from Antonio Nutrition, and he'll discuss the importance of culturally tailored messaging and language. Following, Donna Rice and Michelle Poltz from Diabetes Sisters will give an overview showing how using feedback can help meet people where they are. And lastly, Paula Green Smith and Peter Rome from Black Women's Health Imperative and Urban Health Resource, respectively, they'll discuss the importance of being flexible to create safe spaces. Now, each organization will have 15 minutes to share their work, and following the presentations, we'll have a Q&A. So I will turn it over first to Sarah and Stephen to get us started.
Thank you so much, Keith. And in the spirit of the accessible intro, I will say that I am Sarah Johnson, the co-president and CEO of ProChange Behavior Solutions. And I describe myself as a white woman with long, curly, light hair. And today I'm wearing a blue shirt and sitting in front of my actual backdrop, which is some art and some plants and books. Stephen, do you want to introduce yourself?
I was thinking we should do it in reverse, but I'm a Black man with a white hat on, and my COVID beard. There's a little salt and pepper there, and I'm the professor at the University of Maryland School of Public Health, director of the Maryland Center for Health Equity. That's my first.
Terrific. Thanks, Stephen. We are both really honored to be in conversation today with our fellow panelists and with you all to really explore some community-centered strategies that can hopefully increase recruitment and retention in the National DPP, and specifically to talk with you about Communities United Together for Health, or Cut for Health, as we affectionately refer to it as. And the purpose of this project, or this program, really was to reduce inequities in diabetes prevention by activating Black barbers and hairstylists as agents of change and deploying tailored, culturally responsive, interactive text messaging solutions that could deliver personalized behavior change messages and referrals to local recognized national DPP programs. And the impetus for it really was to explore the extent to which we could activate Black barbers and stylists as trusted members of the community and trusted community influencers as bridge builders and gateways to evidence-based programs for diabetes prevention, specifically through having them engage in behaviors they're doing already every day, where people are engaging in trusted ongoing conversations in the sacred spaces of the salons and the shops, as well as introducing the availability of this tailored text messaging solution that delivered behavior change messaging to help increase people's readiness to participate in the National Diabetes Prevention Program, as well as their readiness to engage in key diabetes prevention behaviors. And in addition, this tailored text messaging solution allows us to provide zip code matched resources to community services that help address the unmet social needs that are too often additional barriers to participating in the national DPP. So on this slide, what you can see is that one of the other ways that we're helping to reduce barriers to participation in the national DPP is by taking a very population-based approach to recruitment in the first place. any community member who came to the shop or salon could join Cut for Health, which helped us raise awareness of prediabetes risk in the first place. The individuals who were already living with diabetes or who were not at risk for prediabetes did receive some tailored text messaging and those referrals to community-based resources for unmet social needs. But our real focus was on people living with prediabetes. And they received up to 12 months, or are receiving, I should say, up to 12 months of tailored text messages that are heavily based on the trans-theoretical model and other behavior change theories to increase readiness to engage in those key health behaviors and readiness to engage in the national DPP. And when people are ready for the national DPP, we're providing zip code match referrals to local programs that are either in person or virtual, depending on the person's preference. And more importantly, an opportunity to participate in the asynchronous national DPP on the HALT platform, where their barber or stylist is the lifestyle coach for the national DPP, which is so exciting. And in addition, anyone who has prediabetes also is invited to receive a SMART scale, which helps us capture some of their weight data. So that's a high-level overview of the program, but one of the most important elements of its development is that we relied so heavily on human-centered design to co-create this solution with the barbers and stylists. So I'm going to hand it over to Stephen to tell you a little bit more about that part of the process.
Thank you, Dr. Johnson. You know, in many ways, this is one of the silver linings of the pandemic. I want to thank CDC for allowing us the flexibility to use these new methods for co-creating our solution. And so when the dust settled and the people in the barbershops and after we did all the campaigns said, "Hey, Dr. T, that's my nickname there, you're going to give us a jab for COVID and leave us with the diabetes? Wow. You're going to give us the jab and leave us with the cancer?" And we said no, and we had enough infrastructure to be around when this opportunity presented itself. And this is the embedding of this high tech and high touch. We had an empathy-based approach. And using human-centered design, we literally co-created the strategy for implementation. That included the logos. We did all of this in Zoom. Again, the pandemic made Zoom a platform for training. We created a community of practice. These are independent businesses. These are not churches. They typically don't get together. They compete. They cooperated and recognized that even their back-to-school activities was a representation of their collaborative nature. So, yes, we traded on their goodwill for their community, but we also provided them training and resources. Next slide. So you just see some images there, and it's interesting because we said, why not go where people already have trust? And I'll never forget one of the barbers saying, you know, going to the doctor takes the smile off my face. So these are realities and looking at things through their eyes. And so here we are in their congratulations. And this creation of the emojis was in many ways to address the underlying grief. We are in neighborhoods where there is a tremendous amount of grief, of loss during the pandemic and afterwards. And this topic is not an easy one. And it's one where people sometimes get blamed. And so this congratulatory atmosphere was one of the ways in which they owned it. Next slide. And Sarah and I will talk about this because at some point they went away from the emojis and said, I want my face on the poster. I want, my shop in the background. And they began to come up with creative ways of bringing people together, like Brunch with the Brothers. And in this context, they exercise their ability to launch pop-ups around specific topics. And Sarah, talk a little bit about the use of our QR codes and our ways in which we really gave them agency in this program.
Absolutely. Thanks, Dr. T. So as Dr. T mentioned, there were a number of ways individuals could access the program. And the Memojis, in addition to being sort of celebratory, were also partly driven by one of the conversations we had around trust, that if a person in the community was receiving a text message, they needed to know that it was associated with the program and with their barber or stylist to trust it more so that they wouldn't perceive it to be a scam text message, for example. So the program logo was attached to the text messages, and then Memojis were attached to all the promotional materials and the recruitment materials that the barbers and stylists had in their shop. And we'll talk a little bit more about that. And I just also
let me just say that shield That shield comes from the history of Black barbers all the way back to the time of the colonial times and the antebellum times. So we went into the history of this field and used images from that history and then shared with them their own history. Many of them didn't know their history. Again, it gave them more agency. Sarah?
Yes, thanks, Dr. T. So, one thing I just wanted to emphasize is that all of the barbers and stylists participated in the full training as lifestyle coaches and have since participated in their refresher training. And the congratulatory memoji so with the graduation caps was the way we celebrated that with them. They all very proudly displayed their certificates in their shops and salons on their mirror, and that was one point of conversation with their clients. But they also, throughout the process, of this project, had been meeting with us weekly in what we call a team huddle on Monday evenings, which we specifically chose because the shops and salons are closed on Mondays typically. So every Monday night at 5:30, we convene for just a half an hour. And it really provides a forum for them to share successes with one another and to celebrate those successes. And also to do essentially create a community of practice in which they're coaching each other and providing a lot of peer learning. So throughout that process, the co-creation has continued, and there's been a lot of iteration and refinement of everything from the how we're displaying the consent form to some of the recruitment materials. One of the trust elements, for example, that emerged from that process was that our consent form in the text messaging program is a PDF that is displayed with a link that someone could use to view the full consent form in a web browser. But on your phone, you might imagine that's a small font. And that presented a barrier to trust for some of the clients who wanted to know the details about how their data would be protected, but couldn't see very easily on their phone. So through conversation with the barbers and stylists, we printed out the full consent form and laminated
Old
it. So
fashioned.
yeah, old fashioned, old school. And so they could hand it to their client while their client was having their hair serviced and be able to read the consent form and be much more comfortable about the process and how their data are being stored and what the terms of the research were. So,
And you know,
and
Sarah, I just wanted to say that in addition to these technical issues we're describing to you, they came into that room with what their day was like. That's when
yes,
we learned about the grief. That's when we learned about the anniversary of a murdered son. That's when we learned about the death of a loved one. And that is part of this. I think the
absolutely.
message is we're going from engagement to commitment. And that's the message also to all of our public health friends. We're going from engagement, we're doing a lot of engagement. They want commitment, and that means listening to their whole lives. And by doing that, they now trust us. They now trust us. And Sarah, I want to let you know that Sarah has been on the ground in the Black barbershops. She has been battle
Absolutely.
tested, and that's important as well. We have to show up.
And that trust, if we could have the next slide, we're wrapping up to make sure we have time for everyone else. This is an example of how we created a chat group so that everyone could communicate with each other and share. This is the custom cape when Jose decorated his station. He shared that with everyone in the group. And then the very last slide shows that that trust has been translated to the community. We were able to invite over 400 community members to participate in Cut for Health. And as you can see, 183 of them were at risk for prediabetes and therefore eligible for the national DPP and have had the opportunity now to just make a selection about their preferred channel. And over 60% of the individuals with prediabetes chose the track of participating in HALT with their barber or stylist. So we'll be following them for 12 months and hope to be back another day to tell you more about the results. But I don't know, Dr. T, if you want to say one final word as we hand it over.
Well, this was high tech and high touch. And we have a number of lessons to share about the methodology of human-centered design that can be applied in other settings. Looking forward to working with all of you. Thank you for your time.
We're going to hand it over to Antonio. Thanks so much.
Wow, that was amazing. And I love Dr. Thomas and Dr. Johnson. High touch is just that's a tough act to follow because to go a little bit off topic of what I was going to mention is that I think it's just so beautiful to see over 300 people here virtually and to have people like Dr. Thomas, Dr. Johnson, everybody else on the call. Ultimately, what we all care about is about the cultures and more than that, the people that are in these communities. To hear you guys talk about trust and hearing the loss of a family member, it reminds me of why I started my journey to help the Hispanic community. And that was seeing people like my dad, people that are the men that are the barbers, the men that are the workers that are the men and women who are lower income, lower socioeconomic status, who will never be on a call like us like this, but that deserve and have the right to have the best health possible. So thank you guys for giving me that energy. So yes, awesome. So I'll share a bit about what I've done. My name is Dr. Antonio Miranda, and I'm going to follow the theme of one, what are some outside the box ideas, barber shops, in my case, using Spanish slang and linguistics and visuals to help motivate the Hispanic community? And two, really how to humble ourselves culturally, because so much of our time is spent on reading research articles, but not, and while that's very important, much more of our time should be spent like how you guys did on the ground, meeting the community where they're at, learning the culture. It doesn't matter if you're an insider or an outsider. All humans recognize genuine compassion. All humans recognize trust. So that's amazing. A little bit about me. My PhD was in nutrition. I'm a registered dietitian and certified diabetes care and education specialist. My PhD specifically, however, was in a topic that many people like to learn about, which is Hispanic health behavior. How do we reach these very difficult to reach for very different reasons, these populations? And specifically, a bit of a story. The reason I pursued Hispanic health was one day I was walking in my dad's backyard when I was visiting. And I was thinking of going for my dissertation, and I thought, what do I want my PhD to be about? And I looked over at my dad. He was hard at work on a lawn mower. I grew up mowing lawns with my dad, digging ditches with my dad in the 100-degree Texas heat. And I said, you know what my PhD would be well served in? And how to help that guy and how to help someone like my dad. And so that's what my PhD was in, which was in the macho man syndrome. How do we reach these very health resistant populations? And specifically, how do we use language? I'm a speaker, I'm an author. I just published a book that you can see on the bottom right. But ultimately, I'm just someone that's very passionate, like everybody else on this call, to help our niche populations, be it the next generation of healthcare workers or be it the populations that are in front of us. Next slide, please. There are distinct psychologies. My dissertation was 300 pages on that, and we're working on a publication called, literally, it's going to be called the Macho Man Syndrome. So a little bit about the Hispanic health disparities that I came across. Obesity, overweight, diabetes, some of the highest rates of uncontrolled diabetes, uncontrolled hypertension in the Hispanic community. And in the chat, we'll drop the publications that I'll mention. But the first one we did was we went into the community and interviewed 15 Mexican immigrant men, and we wanted to find qualitative data to expand on all the quantitative data that we had. And I simply went to the community and asked them, why do these disparities exist? What's getting in the way? What's making it difficult for Mexican men, for Hispanic men? And here were the findings in summary, in 30 seconds or less. The gusto of food. Every culture, minority or not, the gusto of food is such a powerful influence. The Mexican men told me, we have the tea diet. And I said, what's the tea diet? Tacos, tamales, tostadas, tortas. And I thought, oh my God, that's a hilarious joke, but I get it. They got the message across. Food is very powerful, and where we develop in our environment influences us a lot. Let's see here. Sorry, the chat's kind of popping up in front of me. And then in terms of the behavioral components, or the machismo, the macho man syndrome, the vale madrismo, which is a fancy word for, if you take the literal translation, and this is scientific, this isn't me saying it, it's the reality of men saying, I don't give a damn. That's what they would say. But what I really explore in that article that's coming out is how that's really a facade. That's a fallacy that we use to just avoid the responsibility amid a life of responsibility, especially in the lower income areas. And of course, lower literacy and what do other people know about diabetes influences what I know about diabetes, so on and so forth. So next slide. One of our major findings in the second research article that you see here before you is that these colloquialisms can be used, these colloquialisms known as dichos, or literal slang and phrases, can be sprinkled into your programs. If there's one takeaway from my 15 minutes of mini fame, it's that dichos and learning the slang of your community. I'm sure you guys learned in the barber shops and learned in the Hispanic community, in the Asian community, in the white community. Knowing your culture's slang is such a powerful tool to bridge those connections and to gain trust. And this is an article we published called Dichos and Diabetes: Using Literary Devices to Inspire Health Behavior Change. Because as you can see on the bottom here, when we're trying to change, when we're trying to reach a culture, a lot of times we know the beliefs, we know the language, but knowing the language is really knowing the slang. Dichos speak the truth. Yes, someone's saying that in the chat. Ultimately, using dichos such as you snooze, you lose. So if you snooze on your health, you can lose your health. Or in Spanish, it's called the shrimp that falls asleep gets taken away by the current to the cocktail, right? Those are very simplistic but potentially influential phrases that are so common in the Spanish community that they can be repackaged from colloquial slang to healthcare education, and that's what we did. Next slide, please. To summarize the end of my dissertation, the final research that I did was we did a pile sortation methodology, which is very unorthodox. But what you can see here on the left, and you'll have to rewatch to see all of them, is we took the slang that is very common in Spanish, and we wanted to see how can we reframe that slang and deliver health messages. So you live and you learn. Don't play with your health. Let food be thy medicine. We reap what we sow. Help yourself and God will help you. All these very, where there's a will, there's a way. The shrimp one that I just mentioned, and a preventative man is worth two men. These are so common in Spanish that we said, why aren't we using these? And we interviewed in total in my entire PhD, nearly 40 men, Hispanic men, and asked them about these topics so that we could learn, where can we use you snooze, you lose for healthy eating, for health motivation, for physical activity? And guess what we found? You could use them for a lot of them. They're very robust, and there are articles coming out about it in the near future. Next slide, please. So we actually implemented this not during my dissertation because I already had so much and the pandemic got in the way, but I actually volunteered at a clinic and we ran a 6-week dichos program where there was a dichos. We pretty much took the diabetes prevention program or the diabetes, prevention program and integrated dichos into it. I have a whole curriculum on that I need to implement at some point. And we did a 6-week dichos-based intervention. We saw weight loss. We saw improvements in fasting blood glucose. It was an informal, unofficial intervention, but it still provided great insight. And then in my actual dissertation, we developed this curriculum of over 100 pages, the diabetes prevention program. And what we saw were the knowledge scores increased and the cultural favorability of such a program. And there are novel articles that have come out that dichos are now supported. So next slide. And I'll conclude in these last two slides, firstly, by reading a little bit of how we can scientifically study slang. And this is pretty much an article that I'll submit in a couple of weeks for final approval, deciphering dichos. So we were looking into this dicho, shrimp that falls asleep gets taken by the current. And you'll see what it means momentarily. Camarón que se duerme se lo lleva la corriente. All participants recognize the dicho. Recognizability is important. The participants stated that this was one of the most common Mexican dichos and that it serves to, one, as a reminder of the consequences of negligence, and two, promotes alertness and attentiveness towards life's challenges. Quote, you need to be active, awake, and attentive toward what you're doing, or things go poorly. And this is from our community. I'm so passionate about that too. If we can get out of our ivory towers, there's nothing wrong with being an ivory tower, but going to the community and saying, you're the expert, not me in the suit, not me with the PhD. You guys, you girls are the expert. We want to learn from you. That's such an amazing experience. The dicho was mostly applied for health motivation, 10 out of 12 participants, physical activity, and healthy eating. If you don't get active, if you don't think and reflect on what can happen to you in the future, then the truth is you're going to die. If you don't take your medications, exercise, and get motivated, if you fall asleep, then you're going to be taken by the current to the cocktail, to the grave. They added some humor in there. Next slide. I believe it's the last one. If you snooze, you lose. I'm glad that's resonating with you guys. What are the takeaways from all of this? Because you won't remember all the 15 minutes. Hopefully you remember my passion and all of the panelists' passion. But dichos and understanding slang can help with your linguistic economy. You can explain all of the potential consequences of diabetes and prediabetes. But you know what your participant might remember better? The shrimp that falls asleep gets taken by the current. So stay awake, stay alert. But you have to complement that, right? By saying, I'm here to help you. I'm not leaving you on your own. I'm not being disrespectful. I'm using this dicho in a way from a source of compassion. Cultural camaraderie, building those bridges. Linguistic flexibility, speaking science with slang and speaking cultural colloquially, or sprinkling science into our culture. And so my last tips would be practice with your family, then practice with your population. Because once you feel comfortable enough with your family, you know you can use them in a manner that's respectful and encouraging. And reach out to me, antonionutrition.com/inquiry. I think they'll put it in the chat. But reach out to me if interested in learning more. But I'll conclude by saying this. One of the most common phrases in Spanish, it's ya valió. I was just diagnosed with diabetes. It's all over. I'm screwed is pretty much what they're saying. But imagine the power if we can change our culture and our slang from going from ya valió to sí se puede, to yes we can. In the Black community, the Hispanic community, and all communities, diabetes isn't death. Diabetes is an opportunity to get in shape, to get better. Thank you so much for your time. Reach out, and thank you for sharing your dichos, and I'll pass it on to our diabetes sisters.
Thank you, Antonio. That was great. I'm just emphasizing the power of language. I loved that. So thank you for sharing that. And on behalf of Michelle and I, we're honored to be a speaker at this program today. So I'm Donna Rice. I'm a certified diabetes care and education specialist. I am a Caucasian woman. I have kind of a short, dark bob haircut, and I have glasses, and I have a pink top on today, and my background is a Diabetes Sisters background with some colorful bubbles that my top matches today.
Thanks. And thanks again, Antonio. Great presentation that we have to follow on both of them. But we're excited to be here to talk to you and share a little bit more about Diabetes Sisters, who we are and what we offer, and how we reach women today with our programs. I'm Michelle Poltz. I'm the acting CEO of Diabetes Sisters. I also am a white woman with dark blonde, medium length hair. I'm wearing a green and white pattern dress, and I also am behind or sitting in front of a Diabetes Sisters branded office backdrop. So again, thank you. We're so excited to hear, to share with you a little bit more about who Diabetes Sisters are and what we do within the communities today. Next, yeah. So Diabetes Sisters is dedicated to fostering a supportive and inclusive community for women living with diabetes and then those at risk. And our mission is to provide a safe space where women of all ages, of all diversity, and all types of diabetes or can come together to learn, to share, to be empowered, and to thrive. And without that, I'd like to show a little bit more about who we are.
Diabetes Sisters is a women-led 501c3 nonprofit organization that is determined to enhance the well-being of our members. United by our diverse experiences, we know that living with diabetes is a unique journey that requires strength, resilience, and community. Through educational initiatives and nationwide peer support, we help empower women to share their stories and find the resources they need to navigate their health journeys together. Diabetes Sisters, your journey, your community.
Yeah, we are that, and we're also a partner with purpose, and a partner that actually helps our organizations we work with outcomes based on the programs we put into the marketplace. We've been established for over 15 years. And as we said before, we manage women with all types of diabetes, recognizing their unique challenges on their journey and on their women's health journey. We're committed to create that inclusive space where learning, sharing, and thriving together are at the forefront.
Slide. So at the core of our offering is a value-based peer support model that is really grounded in both qualitative and quantitative research. We know the literature is rich in looking at the value of peer support, and we know from our members that peer support is really critical in managing diabetes, and it really provides that emotional, social, and practical help from women who are living the journey with them. We also are really grounded in 15 years of qualitative research. And as you can see on this slide, that we have so many testimonials that come from women all over the US that really talks about the value of peer support. Next slide. So that is the model, and this is our audience. We know the percent of women with diabetes and different ethnic backgrounds. And we also know from data from the CDC and also from the National Telecommunications and Internet Association that all people really engage and take in information in different ways, either through a laptop, desktop, tablet, or via smartphone. And we knew as we launched our new platform that we really needed to be able to meet the needs of all women. And we do that through our platform because we're both web enabled and also mobile responsive. Next slide. Also, the visual journey through our campaign. So our resources are really designed for women with diabetes and those at risk. We address all of their unique needs. And if you could see the top diagram on the corner, our meetups across the country are led by women with diabetes. And we focus on the peer leader because they have diabetes and they really engage with women and that really come to their meetups. And the purpose of doing this is that people can pick women that look like them, or maybe they're the same age or whatever. So we're really trying to kind of like meet the needs and the goals of the women that come through the program. We have an inclusive approach that ensures that we support women from diverse backgrounds and experiences, and we recognize that every person's diabetes is unique. And then our programs target women that are at risk of diabetes. We provide preventative education and early intervention strategies to really help reduce the diagnosis of diabetes and the prevention and progression of complications. We provide also support for healthcare professionals and caregivers, and we ensure that they have the knowledge and the tools to really help women. And additionally, we do partner and collaborate with prospective sponsors and partners in the healthcare industry so that we could stay abreast and our members could stay abreast of the newest information and therapies out there. And it also helps us further our mission and extend our reach into the community. Next slide. So we're a member-driven platform, and we're also a data-driven approach. Our annual survey told us that 41% of our members were not able to attend a meetup since there wasn't any in their area. So with our new virtual platform, we've opened up our meetups across the US, different days of the week in different time zones, and we're meeting women where they are so that we go to them instead of having them having to go to a place to get education. And we have seen about a 20 to 25% new member growth and positive feedback from our attendees. This just is one example of one of the quotes that we got. Thanks for for really the vital and helpful push from Diabetes Sisters to connect us all online. It's really helping me, as I could never do the one-on-one meetup in my small Colorado town. And I think that meets it. And I think, Keith, in the beginning of the presentation, you talked about there's not one stop shopping for everybody, and we need to have different approaches to meet people wherever they are. Next slide. So we also have an enhanced program. Our new platform offerings are on-demand webinars. We also provide women an opportunity to watch them when they can in their busy lives. And we know that we do them live programs across our social platforms. And then we also have them on demand. And we have a great amount of women watching them on demand. They're connecting with peers and they're learning from peers. And we really think that that's the key in the support model is being able to really share that lived experience is so important. And I know another quote, it says it was really helpful in learning new strategies and success points on my journey, just to know that they're not in doing this journey alone and that they have support and they have people that they can count on. And these are just two examples of the way we actually market our programs and our webinars.
Yep.
Next slide. We also have expanded content. So our new platform offers, like I said, on demand. We have pre and post event surveys. And one of the things I did mention is that it's member driven. So we do pre-event surveys, whether we're looking at like eye disease or kidney disease or whatever the topic is. We actually survey our members to see what's missing out there, what's the gaps, because we don't want to create more noise. We want to augment what's not out there and really provide the missing and the gaps to our members. We also do post-event surveys because we really want some outcomes. We want to know, did they learn something from the program? Did it improve their confidence? Did it improve their conviction that they're able to really make some of those necessary behavior change in order to improve their disease? And we also are doing a Net Promoter Score, which provides our team with really those valuable insights to explore topics for upcoming and follow-up events that are needed. An example of this, we expanded our eye health content based on survey feedback. We do webinars around eye health. We also do individual workshops so that women who have eye problems could come and actually talk and really work with other women who have really went through that same experience or are having that same experience. And some of the results, they were able to really schedule routine eye exams. They said that they learned a lot about the eye and each function or each part of and how important it was to really good control. And also some of them said that the treatment options for diabetes-related eye disease and prognosis, they didn't even know that they were out there. Here they were suffering with eye disease and didn't really know where to go or what type of doctor to go to, but also some of the treatment options that were available. So I think that says it all, providing people with the right resources and the right connections.
Yeah. And if I can just add on that too, when we ask and survey, it's always about confidence and convinced they can change their behavior in managing their diabetes. And we're seeing such great confidence and conviction results on those surveys as well. So, the program pre shows that there's some, that they're not aware. Post event is that they're aware and they're going to take action.
And one thing I did want to say that we do have several hybrid models where we do both in person and the ability to Zoom and do a kind of like a virtual platform together. And those are well attended as well. And, people on the West Coast, if it's like, 9 o'clock a.m. their time, they could join a program that's at 12 noon and still like benefit from the education. So it's really proven to be a really effective model and really reaching people where they didn't have the opportunity to really have programs or education related to diabetes. Next slide. So what are our next steps at Diabetes Sisters? Well, we have some long-term goals. We really definitely want to expand our peer support networks to reach more women across the country. We certainly want to enhance our educational resources to provide up-to-date and comprehensive information. We know that diabetes is complex. there's more services out there, there's more medications out there, there's more devices out there. So we want to make sure that we're keeping our host leaders and our members abreast of what's going on in the diabetes arena. We also want to build strong partnerships with healthcare professionals and organizations like you to really improve the support system for women, because we know that at the end of a DSMT program or a DPP program, there's got to be something else out there to keep people engaged and to keep them on track with the good things that they really gain. So we'd really like to really have an opportunity to work with all of you and with our peer support model. And how could you help us? There's some ways that you can help us. Volunteer your time or expertise to help reach more women. And also you can partner with us through your organization. So to learn more about Diabetes Sisters, you can go to www.diabetessisters.org. And I'd like to just say thank you so much. And at this time, and Michelle, unless you have anything else to add?
No, thank you for this opportunity. We're so excited to share who Diabetes Sisters is and what we're all about. So thank you for this opportunity.
Yes, and right now I'd like to turn it over to Pete and Paula. Thank you.
Thank you, Michelle. Greetings, everyone. I am Paula Greensmith. I am Vice President of Training and Technical Assistance for the Black Women's Health Imperative. I also have a dual role with our Detroit partner, Urban Health Resource, from whom you will hear from Pete Rome with our organization there shortly. I am a brown-skinned Black woman with curly, nuo, afro kind of hair, it's dark brownish, dark hair, tomato red lipstick, and I'm excited to be here to be able to present this program for you today. I want to begin with a little bit about the Black Women's Health Imperative. We are the first and only nonprofit organization created by Black women to help protect and advance the health and wellness of Black women and girls physically, emotionally, and financially. Now, for over 40 years, we've worked to advance health equity and social justice for Black women across the lifespan through our programs, initiatives, and health policy advocacy, education, research, leadership development, and communications designed to improve health outcomes for Black women. We were one of the original grantees selected by the CDC to take the National Diabetes Prevention Program to scale in the DP 1212 funding cycle. We've been funded 3 times, so we are in the 3rd funding cycle as a grantee delivering the National Diabetes Prevention Program. Our branded program is called Change Your Lifestyle, Change Your Life. And we are also one of only 13 training entities with an MOU with the CDC to train national diabetes prevention providers throughout the country. We also have the first CDC approved curriculum culturally tailored for Black women. So we are excited to be able to talk about our work with Black men. In 2020, we started talking about the need to expand some of our work with our programs into working specifically with Black men. So with the support of the CDC, we repurposed the typical meaning of the men's room for that to be the space within BWHI dedicated to improving the health and wellness of our Black men. Our program is delivered by our Detroit partner, Urban Health Resource. The program utilizes a culturally tailored Prevent T2 lifestyle change curriculum that was informed by Black men to reflect their realities and lived experiences. So hearing about the dichos and how slangs and sayings were applied is right in line with what we've done with this program, because we also changed all the names of each module to reflect more culturally relevant terms for Black men. So our program employs Black coaches, Black male coaches that are trained in our signature high-touch coaching model. And that's a model that we trademarked back in 2016 because we recognized the need to go beyond the basic lifestyle coaching job description to meet the needs of the people that needed these programs the most. We also deliver the program remotely on our BWHI app. We've been delivering programs remotely on our app since 2020. We also equip participants with information regarding the effects of chronic stress on Black men's health and provide support for the Black men in our program to reduce and manage chronic stress. And finally, but not least, we actually provide tools for Black men to prevent and manage type 2 diabetes, and also reduce their risk for other chronic conditions such as heart disease, high blood pressure, and high cholesterol. So before I turn it over to Pete Rome to talk a little bit more about the details of our program, let's take a quick look at the trailer to a video to which you will get the link for the full video later. But this is one that just kind of talks about the impetus of our program and a little bit about the progress of it.
See, men are funny, you know, because one thing that women do that men don't do is women talk. They talk about everything. I mean, everything.
that.
Brothers be like, yo, look, dog, I be knocking it out. I'm this, you know, they be up here with the machismo, if you will.
Yeah, I'm good.
I'm good. I'm good. Meanwhile, dog at the crib crying because he ain't all right.
Right.
But what we've been able to do is you know, talk to men on that granular level.
We're in the men's room. We're having those same conversations, but it's about each other. It's about our health. Hey, are you watching this, man? You know, how'd you walk today? Did you get your walk
Holding
in?
it accountable.
Holding it accountable, right?
Men's Room.
Turn it over to Pete Rome. He's going to talk about the program now and how we've trained our coaches because we are also a training entity. So,
thanks, Paula. Good afternoon. My name is Peter Rome. I am the Director of Health and Wellness Programming for Urban Health Resource and also the Program Manager for the Men's Room. I want to talk about creating and inviting and safe space for the engagement of Black men. I'm a Black man with no hair. I have a red tie on with a white shirt. I have a gray beard and also a blue sports coat. So as we start to talk about the challenges that we were faced with, I just want to run through how we actually started to tweak some of those challenges. First of all, recruitment. We had a lot of interest from Black men, but it always was very, very high. We had a difficult time actually getting them enrolled into the program. Many expressed a lot of interest, but they were reluctant to actually make a year-long commitment. And this is a commitment. It's an intentional commitment to changing your behavior and changing your lifestyle. So we used a lot of sports analogies to help men understand what an intentional commitment is all about. Also, a lot of interest was generated before the curriculum was even actually developed. So as a result of that, we lost a lot of men before we even got started. We also found that we had to do multiple zero sessions or the orientations was required, at least a minimum of 2 so we could get the program going. Scheduling, because men were recruited from around the country, different states, different time zones. We had a challenge trying to find the right time and day just to accommodate those folks. So we ended up really looking at our requirements to get 20 men into the program, and that was really difficult. So we often ended up with 3 or 4 orientation sessions or session zeros to get the program up and running. Technology. Now, I think that was probably our biggest challenge, Paula. Going back thinking about that, just getting Black men to complete the risk assessment or risk test, getting them to complete the intake form or the enrollment form, I think that was one of our major challenges. Oftentimes we found that men just had difficulty with the technology. Everyone just really was not that versed as we thought they would be. As a result, there was a lot of delays in just getting the men into the app. And that caused a hesitancy, just inconsistency in getting the app up and running. One other issue we faced was just overcoming the perception that the program was not a program for Black women. As men received the information and it talked about the Black women's health imperative, immediately a guard went up. And men was like, this program is for women, not for us. So we had to continue to really talk to men, get them engaged, keep them excited about getting into the program. Next slide, please. Gaining momentum. So currently, we actually have 4 different groups going on. There are 2 in Detroit. There's 1 in Western PA, 1 in Georgia, and they're all like 3 different markets. So currently we have close to, I think, 80 men that are in the program right now. So from a marketing perspective, the program, we did a lot of informal discussions. We had a lot of listening sessions. We were guest speakers at the churches, at the health fair, community outings, and we did a lot of formal presentations. Also, for the first groups, which was established for the 100 Black men in Western PA, I was a closeout speaker at their leadership conference. Before I got off the stage, Al Valentine, the president of the Western PA, came up and he stopped me. Immediately said, Pete, we're going to do this. We are going to do the men's room. We have a lot of chapter members that we do a lot of work with. They're out in the community doing all the work. This is a program that we can actually give back to them. We found something that we can give back to them and help them change their behavior and their lifestyle. In addition to more chapters of the 100 Black men that we're working with, trying to get them involved, there's a number of interests there, but also the fraternity groups, the church groups. Also, we've talked to Black men in unions. We were guest speakers for there, trying to get those men involved. We're anticipating this summer and this afternoon, later in the year, we'll have more groups starting up. We're excited about getting more groups in. Next slide, please. The testimonies, I think you heard a lot in the actual video, but I'm going to talk a little bit about some here. The 100 Black men, our first chapter, after the first 16 weeks, they lost 150 pounds. Just incredible. As we got into a session which was called Get Back in the Game, I brought in a former NFL coach, and that actually motivated them to agree that they were going to lose an additional 50 to 75 pounds. They had a new goal of losing collectively 200 pounds. Also, the group in Atlanta, they've lost already 70 pounds. Next slide, please. So the testimonies, we don't have time to really go through all of those, but we just have some incredible life testimonies from a gentleman. Just had a call last week. A gentleman called up in tears, talking about he was able to get off of the medication. He was getting 300 minutes of physical activity. He's losing weight, and he was just so happy to be able to get off of the medication there. Also, in some of the groups, we have some medical professionals. One of our physicians has already lost 30 pounds. We have another gentleman there that's a physician assistant. He's also become our lifestyle coach. We're also working with different members of fraternities, Phi Beta, Sigma, the Omegas, and we're working with those groups to establish more men in the men's room. Many of the groups have become what I call raving fans. They're really true ambassadors to get the men's room program up and going. Slide number 6. Please, next slide. So what we've learned in the program, Black men's voices, they really matter. You know, we found time that we had to really listen to men, find out what's important to them as we started to develop the curriculum. The other thing is just partnerships, having strong leaders in partnerships. And finally, the key, I just really believe, is just staying at it. being consistent, just being able to get men to trust the process, to become champions for their health. Because once they get in the program, we find that they will change their behavior and their lifestyle. They will become champions for their health. If we want more information, we'll be starting new classes here. You can go to mensroom.bwhi.org or uhr-uho.org/mensroom.
Let's get into some Q&A, and we've got a lot of questions. I'll use moderator's privilege to kind of combine similar questions into one. If that's okay. And I'm going to go back to the top of our presentation for Cut for Health. And we had a couple of questions for you, Dr. Johnson, Dr. T, on the incentives that you used for coaches. What type of incentives did you deploy, if any?
There are incentives for the Oh, go ahead, Dr. T.
I was going to say that, let me start with the groundwork, because before we got into the research incentives, there was a relationship in place. And that relationship was built on their passion and commitment to serve their community. And sometimes that passion and commitment gets traded on, where they don't get compensated. So we had a culture where we recognized and respected their time. So when Cut for Health came along with resources, thank you, CDC. Now, Sarah, let them know how we played it out.
Yes. There are incentives in place for the barbers and stylists, and because in part they're acting as interventionists in the research study. So through the contract we have with the CDC, we were able to reimburse the barbers and stylists for not just being lifestyle coaches, but participating for their time in the training and for their time talking with clients in the shop and in the salon about the program. So over the course of their involvement, which extended really, when you add it all up, over about 18 months or so, the incentive for each barber and stylist, which is just a nominal acknowledgement, a token of appreciation for their time, was $2,400 over the course of the whole project. And I think obviously it would be wonderful to in the future have more funds to reimburse, because they are investing a tremendous amount of time. I mean, we had envisioned that the huddles that we have each week would only be occurring during recruitment, but have gotten feedback from them that they're useful and that they appreciate them. So many of the barbers and stylists are still participating, even at this point, long after recruitment is over, in those weekly huddles. So it's really just a small token of appreciation for their time.
And that small token was a big lift even to get them paid. So this is another issue around the structure, the W-9s and the all the contracting. Those are heavy lifts too. Thank you, CDC, for giving us time to do that, because now they're paper ready for other engagements and for documenting an important part of how you keep these programs sustained.
Got a question for Dr. Miranda. There were a number of comments and questions about interviewing people from different countries, and if that was part of your research, and how well the dichos and slang approach would work for different countries, communities. There's Venezuelan communities, et cetera. How would that play out across Hispanic communities?
Yeah, it's a great question. As an academic and from a research perspective, I answer it by saying kind of how we're doing today in terms of we're switching from minorities to these hyper-local subcultural groups. Now we know the importance of all of that. It used to be we had research on Hispanics, but now we have Hispanic research on Mexican origin men or Venezuelan origin men or Mexican origin women. So now I wasn't the first. It was probably the early 2000s when a couple articles came out in Mexican origin men, but we were the first in 2020, 2021 to look up dichos in the specific subgroup. So academically, there aren't any other articles on dichos in very many other groups, but as a member of the culture, dichos are arguably universal in all Hispanic groups, but there's definitely going to be regionality. There are different dichos, just like there's different slang in New York versus Boston versus Texas. Similarly, across his Latin America, you're going to see different dichos in northern Mexico from southern Mexico, but that's what opens the door to all of you who conduct research or who are interested in pursuing their PhD or in doing research. You might be the person that leads the charge. That's what gave me so much energy during my PhD, because it was brutal during the pandemic, but I knew I was the first one leading the charge in a particular subgroup, and that's a beautiful thing to get involved with. So they're fairly universal, but in terms of science, we have more work to be done. But thankfully, we have probably 10 publications coming out in the next couple of years. It's just a matter of writing them on the macho man syndrome, on fatalism and the God phenomenon, Mexican men, on dichos and different strategies to use them. So over time, they'll reveal themselves a bit better. Great question.
Yeah, well, you hit it. There will never be a shortage of work in this work. Well, let me take that back. We hope that there will be a shortage of work in this work one day. How about that? So for Donna and Michelle, diabetes sisters, is there any eligibility for people to join or a related cost to join?
Well, there's no cost to join, and to be eligible, it could be women with diabetes to be a host leader, but anyone could access our webinars, right? It could be a caregiver, a healthcare professional. And when you sign into our platform, you tell us who you are, and then the platform helps to really kind of like identify kind of needed content or whatever specific to that individual. And there's no cost to individuals to join.
So I'm going to throw this next question to our friends Paula and Pete. The comment is, our organization is struggling with getting men to participate in our lifestyle change program. Any recommendations for first steps on recruiting men?
I'll start with that. Pete probably will chime in on this, but I think that one of the key recruiting strategies for us was partnerships, as we noted. We went to organizations where Black men were already engaged, were already committed to a cause, and we worked with them. First of all, most of those organizations, whether they be churches, fraternities, other kinds of organizations, professional organizations, they all typically have some health and wellness committee or initiative that they're working on. And so one of the key strategies that we kind of put in place after we started recruiting with them is we said, okay, look, we know you have these initiatives, but you may need some assistance with them. So even if you don't have any members interested in joining the program right now, let us look at what your health and wellness initiatives are, and let's see if we can help you identify a lifestyle coach within your organization, someone that can be trained as a lifestyle coach to work with us and facilitate the program, but also work on your other health and wellness initiatives at the same time. That opened the door for the major partnership with the 100 Black men. But we are also, again, as Pete mentioned, we're working with different fraternities, and there are men's ministries at various different churches that are also in the process of recruiting members and getting someone trained to become lifestyle coaches and deliver the program with us. Now, it's important for us to note that as a part of our training requirements, even though we train individuals from those organizations to be lifestyle coaches, and that's the benefit of us being Black Women's Health Imperative, being a training entity, we train those individuals to become lifestyle coaches to work with us, but they are partnered with a seasoned lifestyle coach. They can't just jump out and run and deliver the program on their own at first. Mm-hmm. And that has been key for us. Pete, did you want to add anything to that?
The only thing I would add is that we just spent a lot of time going to the churches. We went to the golf course, to sports bars to talk about the program, just trying to recruit men to just take a look at it. And those are all the things I can think of right now, Paul.
If I can add one other thing, one of the biggest pushbacks is we see with all of the lifestyle change programming, one of the biggest pushbacks is I can't make a year-long commitment. We'll hear that. But what we were really pleased with, as we have found in running our programs for the general population, by the time they got to the second half of the program, that first group especially, by the time they got to the second half, and it was time for them to meet less frequently than every week, they did not want to stop, and they don't stop. They continue. They meet every week, because that group is out of Western PA. And so even though the program is delivered remotely, we encourage them to get together in person. And they have done so, and they continue to do so, even though they're in the second half of the program.
So here's a question that anyone can jump in and answer, or all of you can jump in and answer. You know, beyond metrics like weight loss, lower A1C, and those things related to a program, what are some of the metrics you use to gauge success? And how have you been labeling your particular success, particularly with your unique approaches to working with communities? And this is open season. Anyone can jump in.
Antonio, you said unorthodox, so I'm going to give you an unorthodox, because Dr. Johnson and I are 1-2 punch. We got all the metrics, all the numbers, the charts, the graphs, the breakouts. But here's what we're not capturing. I saw someone helping someone. And if we're not recognizing that getting them comfortable in these online spaces using these tools, they're going to be left behind. So I saw someone helping an older person, or helping someone who didn't have, whatever their excuse was, they were gentle with them. They did not blame them, because our people think if this doesn't work, they're stupid. We're not capturing that, but with our own observation and our testimonials, we'll try to gather that. But that's an important, I think, development not to be lost. We're leaving capacity in these communities to take charge of their own health, to get on that portal, to be engaged with their health professional. Sarah?
I would add sort of the unmeasurable ripple effects. I mean, I agree completely with Dr. T, and would add that, for example, one of our stylists said recently that people, now that recruitment is over, are still coming in and saying, oh, now I found out I have prediabetes. Can I still join that program? And we've now equipped all the barbers and stylists with that list of local resources, so they can refer people to them, to all the recognized DPPs in the community. But that sort of ripple effect, that the coaches will go on being coaches. And in fact, 2 of the stylists asked last week, how will we continue to get our CEs to maintain our lifestyle coach status when this program is over? So we've connected them with the Department of Health in Maryland. So the ripple effects of this that will live on are hard to quantify and to measure.
But we just did. we just did.
Totally
so the
agree
narratives work. Go ahead, Paula.
I would totally agree. All of those are so important. And I would add to that the sense of community that this program has created, not only in individuals that were already affiliated with other organizations, but they recognize the benefit of engaging with others in their communities to build the camaraderie, the sense of community, the sense of a bond with others that understand them and that could come together with them in a safe space for them to really share what they are really going through. That's part of what you'll see if you see the full trailer to the video, where the men really talk about the fact that, yeah, you know, we are in these other groups, we're in our families, we're with people all the time, but rarely are we in a space where we can really be connected to someone in a way where we can just open up and share what we're going through and what the challenges are in us just being on a journey towards better health. So I think that that sense of community that they build with each other, but also beyond the program, and that they go out and work with others to create, is a real plus. And we have seen that in individuals that have said, yeah, I'm working with this group, but I want to be a lifestyle coach so I can go over and work with this, or I want to take it to this group, I want to take it to my church or whatever. And so that is just something that that is just something to behold for me.
And Paul, I just want to add to that is that things you just can't measure when people come in and say, you actually saved our life.
Yes.
And we've had a couple participants come in and say, my A1C levels were 14. I talked to you, I got in the program, you changed my behavior, you saved my life. You can't measure those things.
So Paul, let me say, I think that we can measure it by virtue of the testimony that you just gave. Our challenge is we can't make the attribution. We can't say that that change happened because I did this or many other factors. But I would not deny our eyes. And that's what the community is telling us. You guys have seen this stuff. You've been documenting it. Why are we still sick? And so that is this next level that we're going to. And all of the presentations today had this theme of the camaraderie and and our barbers help us translate, Antonio. I saw love, and they translate that to mean leaving others very encouraged. LOVE. And every one of the presentations did that. And we should not be afraid to use that word because they really want to know, do we care? And there's a reason why they have to ask that question.
I know everybody's going around that all the awesome answers. I'd echo from the Spanish perspective. Being culture changers is very important. It's everybody's here doing that because all communities have some form of resistance, especially in the kind of the trickle down effect, right? If I always say if you get one person to make a change, it'll be easier for the next 20 because right now with these communities that are lower tech, lower income, they're not going to look up what an A1C is and all that stuff. Their diabetes can be scary, but now we can change the culture and the outcomes and get the indirect effect of, oh, diabetes doesn't always lead to amputations. Diabetes doesn't always lead to blindness. I have a bunch of friends with diabetes, and their lives got better when they took it serious. And in Spanish, we use the word. And I love the love example, leaving others very encouraged. That's we all have a bit of imposter syndrome, I'm sure. Like, are we actually making a difference? But in Spanish, the word is ánimo, which is morale, to have zeal. And no, that's something that we might not be able to measure, but that encouragement that we leave the community is just going to go on forever.
I really like that. And I want to go back to the initial question presented to Pete and myself, and that was, in the challenge, how do we overcome some of the challenges in recruiting men? And beyond the partnerships, we also, I don't care whether you go through partnerships, you talk to someone individually, whatever it is, we got to recognize most of us, but especially men, I'm going to go out on a limb and say, especially men, but most of us don't want to be told you're wrong. You got to change. We've got to meet people. We can't just say meet them where they are. We really have to mean that and approach people in a way that's not judgmental. And so, or it doesn't come off to them as judgmental. And so to say to someone, we would like you to join this program, we have to look at what their why is and align the program goals with their why. Their why may be, hey, I just want to get away from the family and have an outing with the guys. Well, good. Got that in the group. Their why might be, hey, I've gotten some news from my doctor. I'm a little nervous. I don't want to share it with my family, but I need to do something about it. So I think that how we frame the program, how we adjust our presentation, even our marketing has to be adjusted to meet the needs of the individuals that really need it the most. And that's what we mean by meeting people where they are versus saying, hey, I heard somebody may like this phrase, so let me only use that phrase without doing the total package that's necessary to bring them to the group and keep them engaged.
Well, that's perfect tie-in, Paula, and it might lead us into our last question because I want to hear from everybody on this one. As I was listening throughout your presentations and this Q&A here, we talk about high touch being personal and personable and being multimodal. But the common thread that I'm hearing is that active listening. And that's just what you described, Paula. It's like really, really actively listening, because that allows you to not only understand where people are truly, but also understand how they speak to one another, not just to you. So I'd like to hear from every one of you, starting with Diabetes Sisters, and how you leaned into that listening approach and that strategy in your work, and how that has helped you to flex and adapt from maybe from your original plans into doing something different or more of what you're already doing.
Yeah, and I don't know, Michelle, I think I'll just jump in here because I just kind of wanted to add a few comments, and I, ditto what everybody says. And I think one of the most important for Diabetes Sisters when you talk about listening is we survey them. So we survey our members, but we also have an insight platform that looks at what's going on in some of the hard to reach communities. And we take those learnings and we actually then provide the right digital content to really give back into those communities. So we're in the process of launching a Hispanic program. We also are launching an African-American program in some of the channels and the digital platforms that they are living in right now to answer those questions. But when you talk about listening, we have to hear what they're asking for and not repeating content, but really creating content that makes sense to them. And I think that's the important thing, is really listening to what their needs are. Our host leaders are well-trained facilitators. They're learned to listen, active listening, and then to really help us as a leadership to really provide that right information back there, the right content and programming. We also find that we've been around for 15 years. Peer support is kind of this wonderful thing that I think is so ignored, right? And there's really no start and stop. And I think the beautiful thing about peer support is maybe they're going through a divorce or they're going through cancer treatment. People come in and out of peer support when they need it. And they need that support. They need that listening. They need to listen to other women who are going on that journey. And I just think that, when you talk about listening, I think that's probably 100% of what Diabetes Sisters is about. We listen to what those needs are, and then we make it happen and provide the right resources to really help them.
Yeah, I ditto that. Thanks, Donna, it's the basis of our, of how we moved forward in the past year, is really understanding the conversations that are out there. And we did, like you said, we don't want to create more noise. We want to create the right approach for people when they need it, and we're there when they need it to be pulled in to the conversations to the group settings, or to attend a webinar on demand, or even just download resources around the tips. So we want, like we said, we want to meet where people are, where they are in their given day, not asking them to do one more thing, and be that resource. But because of listening has really helped us inform what we're doing and how we move forward.
Thank you, Dr. Miranda. And I recognize that we're right at 4:30, so I want to be respectful of times, but we'll give you the final word in this area.
And I'll be really quick, just to give everybody specific ideas of what you can do in terms of how to better serve your community. Number one, do a literature review or come to seminars like this. You don't need to reinvent the wheel. That's going to add way too much work to your life. See what other people have done. From there, look into on PubMed community-based participatory research. That's the research method which goes into the community, and there's so many different strategies to learn from your community in a scientific, effective manner. And then the last thing I would say is look up grounded theory research, which is where you're learning from your population in a non-judgmental manner. I went in thinking Hispanics were fatalistic. The literature is actually incorrect on that. And I left with an open mind, or I went in with an open mind, and I realized Hispanics aren't fatalistic. There are barriers. It's a facade. It's a deflective technique that you see in other cultures. So yeah, literature review, look up strategies, do non-judgmental research and community-based participatory research. Just wanted to leave some final tips. Thank you.
And I know we're over, but all of that, I think about the foundation for everything we do is high touch coaching. And that means that with our signature branded high touch coaching method, authenticity is promoted, not just from our coaches, the level of our coaches being authentic with the participants, but a two-way authenticity is promoted at all times, where we recognize that we're creating a safe space, and we're also recognizing that the participant's voice is the most important in that space. So we're always listening and applying what we learn from them to how we can better the program to meet their needs.
So we developed it.
Fantastic. I mean, we could obviously talk a lot longer about all of this, but I want to thank all of our presenters for sharing and
We're clapping.
your candor. Yeah, your candor in the questions. So this is going to officially conclude our webinar. Be sure to get your continuing education credit. Instructions are on the screen and will also be emailed to you. As a reminder, a recording of this webinar and the slides will be shared in the near future. Thank you so much for joining us today for more